Good evening to all. Thank you, Chris, for giving me the opportunity. Coming to my case, our patient was a 50-year-old male who was a chronic smoker. He was non-diabetic, non-hypertensive. He was admitted with complaints of chest pain of 8 hours duration. ECG was suggestive of acute inferior wall STEMI. Echo showed regional wall motion abnormalities in the inferior wall with a normal RV and LV function. Patient was taken for primary PCI. These are the angiogram suits of left system, which shows normal LAD and LCX with retrograde filling RCA. This is the RCA suit, which shows 100% occlusion from mid proximal RCA. Our strategy was wiring of the lesion followed by thrombosuction. Then we will be doing a pre-OCT to look for the plaque morphology, size the stent, then bed preparation if required by pre-dilatation, stenting followed by post-dilatation, then post-OCT for optimization, apposition of the stent and to rule out any complication. Initially we wired the lesion. After wiring also no flow is seen. Then we went ahead with thrombosuction. After thrombosuction we can see TIMI3 flow. Then we went ahead with pre-dilatation. Then we went for a OCT study which shows fibrotic plaque with dissection due to pre-dilatation in the mid part of RCA. This is the plaque. Then we planned for stenting the proximal to mid part of RCA with Giants Expedition 333 mm stent. Then post stent, everything okay with good flow. Then again a OCT run was done to look for stent apposition, which shows good apposition of the stents. As we can see by the white dots. And this is the proximal part, which also shows a good stent apposition and expansion as well. Then as soon as final suits were taken after removal of wire, there was 100% RCA occlusion. Our mouth was also open like that. What happened? Then we rewired the lesion and suits were taken immediately to know what went wrong. After rewiring, we saw there is TIMI3 flow, but a small amount of edginess can be noted in the osteoproximal part of RCA. Then we again went for the OCT run, which shows a large dissecting flap involving the intima as well as the media in the osteoproximal part of RCA. Coming to the OCT analysis, this is the resecting flap around 180-degree involvement involving the media as well as intima. Now, why the dissection occurred? There is an effect known as a razor effect. During pulling up of any OCT catheter or balloon or stent, the guide catheter gets sucked in and result in tearing of the media or sometimes intima as well as media, which happened in our case. And the type of dissection was type F dissection. Then we planned for stenting the osteoproximal part of RCA overlapping with the previous stent. Then with the results are TIMI3 flow. Then again a OCT run was done to look for the proper opposition of the stent, which shows good apposition. This is the previous stent and this is the osteoproximal part, which also shows good apposition and expansion. Coming to analysis, this is the proximal part of the stent, which was good apposition. Some amount of malapposition was present in the osteopencil tract, which was part was done. These are the pre and post final results. It shows good P3 flow. Now lessons learned from our case. Hastily pulling out of guide wire with OCT catheter may cause osteal dissection due to guiding catheter being sucked in, which is known as razor effect. Crossing into the true lumen may be challenging, but in our case, we were fortunate enough that we could cross into the lesion. Imaging with OCT delineates the cause of closure, extent of dissection, and to plan strategy to tackle the dissection. Important for precise angioplasty, intravascular imaging either with OCT or IVUS is an adjunctive tool for better long-term outcome with reducing MACE. Liberal use of IVI should be encouraged. Thank you.
So I think Florent was going to say that maybe the IVI caused your dissection. So I prejudged his, I knew his excitement. So he was getting very excited. I want to make a point. I kind of, and when your last statement came, I was pretty sure that's what he's going to say.
Because I want to stress the important educational factor. I don't know if you injected manually or automatically.
Automatic with the injector.
Injecting manually.
Injector, power injector.
Power injector.
Yeah, power injector.
Yeah.
Bring up your slides again.
So if you do a power injector and your catheter is not really well positioned, then you can easily induce such a dissection. So I think this was not a razor effect, but this was just injecting into some plaque, maybe proximal.
I totally agree. And the question is, again, whenever you showed an angiogram with good flow and you're done, why are you taking another angiogram with the wire out? Because the wire was stabilizing your guide. Go back another one. Okay, go back another one. So show us the angiogram before you bring your wire back, and you're done. Okay, so go back another one, and you showed an OCT. Yep. So go from there. Okay. So play from there. Yep. Next slide. Next one.
Sir.
Okay. Yep. So why are you doing this angiogram? No, this is the one that caused. Because this is the one that caused the issue. This is hydraulic dissection. So the point is, why are you doing an angiogram without the wire? Having done one with the wire and showing you've got a perfect result. And then you're injecting into the wall.
Just as well that they did this angiogram, because it was. See, there was a point made in your previous session, which was there was some discussion about residual dissections, and I was reminded of a 20-year-old paper.
This is hydraulic dissection.
This is hydraulic.
Just go forwards.
But a 20-year-old paper, I think Pat Sarice's paper, he says that if you pull out the wire and wait for 10 minutes on the table, and if the flow, it will usually continue to flow. That was in reference to the earlier discussion. But in this case, I think what has happened is possibly your hydraulic dissection has caused this.
And this is the angiogram with the wire, sir, after stenting.
Yeah, so you're done. You're done. The ostium looks fine, and then you take the wire out and do another angiogram. And you're just lucky that you had the stent in place, because that hydraulic dissection has gone down and hit the stent and stopped. So one of the things you can do if you've got a dissected vessel, some people put a stent down distally like a stopgap. So if you play the OCT, which is very interesting, your OCT is starting in the false lumen, and then you're re-entering.
So one of the biggest challenges in a case like this is that you should not end up
but it doesn't
placing
matter.
a stent in the false lumen.
But you're going to stent in the false lumen, because that's where your wire has gone on the OCT. If you play the OCT, play the next OCT, because you've got the stent there, you've got a target.
The wire was in the false lumen.
And therefore your wire has gone. So look at the OCT.
This is the OCT run after rewiring.
Yeah, so this has come from distal to proximal, so you're within the stent, and then from here you're in the false lumen. So this is in the dissection.
You have to understand which is the false and which is the true lumen here.
Doesn't matter.
Mostly, sir, it is in the...
It's gone from the false to the true lumen.
Yeah. And you're coming out to the ostium anyway, so you've created a neo-ostium. All of that doesn't matter, but I just think this is preventable if you didn't do that check angiogram. But it's a lovely OCT of a false lumen. I haven't seen one of those.
Absolutely, and I think for the right coronary artery, you can easily do very nice pictures without power injector. I understand, for the left system, sometimes you need the power injector, but for the right coronary artery, usually you create beautiful. So in my lab, it's forbidden to use a power injector for the right or OCT.
Yeah. But it's a great case, great example, great images. Thank you.
We all live and learn, and that's why we all here for this 9 to 12 horror show.
But it doesn't matter that your stent is in the subintimal plane. That doesn't matter as long as it starts in the true lumen and finishes in the true lumen.